And we will, and our panel is here getting into some folks who've joined us from a spectrum of society, from legal representation to community health workers, community help promoters, and some more will join us even as we continue in that conversation. And we'll have a chance to interact one to the other to get to know the real state of things as we do that. Also joining us in the studio, in the hot seat as well as we do this, is no stranger to the Situation Room and no stranger to the health conversation that has been taking place in the country from over the last couple of days, and he's going to also help us out in this morning. Dr. Brian Lishenga is the chairman of the Rural and Urban Private Hospitals Association of Kenya and joins us this morning. Dr. Good morning.
Good morning.
How are you doing?
I'm good, Ndu. How are you?
I am okay. I'm all right. Doing okay. Dennis also, as you can see, as well.
Yes.
The state of health is an interesting one at the moment. Yeah. We're going to look into it today, and we're just going to be open and honest and say what the true situation is and perhaps what needs to be done. And we're going to hear from the ground, and we're going to hear from the people as well. Okay, so before we get into that, Dennis quickly is going to share today's proverb, and it might be interesting in terms of what it is and where it's coming from.
Okay, so our proverb this morning, which I'll be seeking interpretation, is coming from Egypt.
Egypt.
You've been to Egypt?
It's one of my to-do lists. In fact, I was talking with a friend yesterday and said I must visit Egypt and spend 2 weeks there.
Doing what?
It's a beautiful
walking around. It's apparently a very beautiful, amazing, and just the amount of human history that is present in Egypt is something to look at.
The oldest civilization. That's where they say math came from.
Yes.
So how about medicine? Where did it come from? Egypt as well?
Again, origins of medicine are a lot of it in Egypt.
A lot of it in Egypt.
A few in Mesopotamia, Sumeria, but Egypt really, cradle of all our intellectual, civilization.
Very interesting. Yeah. So besides that, they are also very, very good in coming up with proverbs. So our proverb today, a monkey in his mother's eyes is a gazelle.
No.
How would you interpret that? A monkey in his mother's eyes is a gazelle.
Oh, wow. Okay, maybe I would interpret it to mean that from a mother's perspective, their child can do anything, can achieve anything, can be the fastest.
Even though they are not.
From a mother's point of view, a child's potential is limitless. It's unlimited. It could as well as even be a lion, or anything. That's how I look at it. So it's the limitless potential that parents see in their children. Yeah.
I love it.
Yeah.
Great interpretation. Basically, is to a mother, a child is always the most beautiful,
Absolutely.
the most wise, the most intelligent, the most fastest.
There's never been a better baby born.
No criminal records.
Nothing.
Even if there is evidence that they are criminals, speaks of parental love either way.
Yeah.
Absolutely. Okay. It does. So as we get into this baraza this morning, we're looking into the state of health in the country. And I know that there's a lot circling the drain in terms of payments for SHA, whether SHA is working, whether folks have an opportunity to go into hospital, and whether we can actually be fair enough to say, you know what, for anybody who's paid their premiums every month and has paid up for a year, you should be able to walk into any facility, be it public or private, and then get the care that you need. That's the overall thought.
Yes.
Right? And then the horror stories of what we're hearing is actually happening in some areas when it concerns people's health. Those are some of the issues that we're going to look into today. To get an overall perspective, let's start with you, Dr. Lishenga, and where we are with health. And I know that Rufa at this point has done a number of things. Topmost on that is saying, you know what? We are going to withdraw services as medical practitioners. I think now we're in another 12 days.
9 days.
In another 9 days, we're going to withdraw services if we don't get the money that is owed to us. Now, let's establish that this is for services that have already been rendered to people in terms of medical care over the years, not just the
For a long time.
For a very long time. And so people have come, they've gotten treatment and they have gone home. They've used their cards, but that's the way the system works. That you essentially are paying arrears in the system. And so Rufa gave that notice, but what is it coming from? What is the premise of that notice? Essentially, where we are saying that medical staff, at least in these facilities that this umbrella body sits over, that medical services will be withdrawn.
All right. Thanks, Ndu. So, just to give you context, a good example is the difference between leadership and management, just to use that. So Rufa is providing leadership in this context. You know what, they say that when you are leading, when a group of people are moving, managers through a forest, what managers do is try and make sure that people can navigate the forest to the end. But what leaders do is they climb the tallest tree and they look around and they say wrong forest. So what Rufa is doing is providing leadership, and we have climbed up the tree of healthcare, and we are now sounding the alarm that this is the wrong forest. It doesn't even matter whether we will get through the forest. It's just the wrong place for us to be. And let me just put it in perspective. When this brilliant idea by the national government was put in place, of course, there was a lot of debate, but we came out ultimately and said, this is the manifesto of the Kenya Kwanza administration. Every government is elected to implement its manifesto. And therefore, why not? Let's allow this government, because it has the will of the people, to implement. So we supported the transition from NHIF to SHA on the basis that the government needs to be given time to implement. Now, what we had misgivings with and what we are sounding alarm on, we're actually sounding an alarm. And it's not only for private sector, it's for the whole healthcare system. The alarm that we are sounding is that the path, the trajectory Kenya is on in terms of social health insurance, if we don't change our healthcare financing mechanism, if we don't change the priorities in terms of where are we spending money, this beautiful baby, back to the baby situation, because the government is like the mother of SHA. So to the government, SHA is a gazelle. It's perfect. If we don't change this trajectory, we are sounding the alarm that by December latest, possibly we will have a healthcare system that has totally crumbled, and it is for one major reason. If you don't put, it goes back to our vision for UHC. One of the major pillars for UHC is healthcare financing. That is to protect people from catastrophic healthcare expenditure, that people should access the highest quality of healthcare without suffering unnecessary hardship. Now, for you to do that, you must put money there. And, we're also telling the Kenyan people, there is nothing like a free lunch. It doesn't exist. Healthcare has to be funded. The question is, where is the money coming from? We as a nation have to decide amongst ourselves, talk among ourselves. Where will we get the money? We want to go to hospital and not suffer hardship. Where will the money come from? And we started from a point, the transition from NHIF to SHA started at a point where hospitals were already indebted. They already had debts from NHIF. Yes, to the tune of 33 billion. And I have been on this show before, Ndu, and I told you that the reason why NHIF was in debt was actually government, not Kenyan people, government, because civil servant schemes, teacher schemes, police schemes, indigent schemes, orphan schemes, Edu Afya, Linda Mama, all these schemes that are government schemes for years did not remit money to NHIF, and hospitals continued providing service, Kenyans continued contributing. So by the time we were transitioning, we were 33 billion in debt. A vast majority of this debt is government debt. Government agencies, ministries, parastatals, all this. So first of all, let's not blame the Kenyan people on that. NHIF was in debt not because of hospitals, not because of Kenyans, but because of government agencies and departments not doing their part. So we said, fine, pay us this money before we go to SHA. They said, no, don't worry. We will write it in the law that any debt or any liability that was in NHIF, SHA will inherit. So you guys don't worry, SHA will inherit. And by the way, SHA is the promised land. We will generate so much money this NHIF debt will look like, peanuts.
Okay.
So we said, fine. Now, 33 billion shillings transitioned. Now, we are 11 months into SHA. The thing I hear from Kenyans is SHA is working. From there, maybe it's a 60-40 split or something. People who have gone to hospital and walked in and walked out and they didn't pay. If you put a microphone before them, I say, boss, SHA is working. Right. But what we are telling Kenyans is that the same trust that we transitioned with in November, October last year, trust in government. So government said, don't worry, we have you. You provide care. Don't turn away any Kenyan. We will pay you guys. Don't worry. So what did hospitals do? Hospitals offered care. And SHA was better than NHIF in the pre-authorization of procedures.
Okay.
NHIF used to reject procedures. You have paid, they tell you, no, we can't do that surgery.
Yeah.
The magic of SHA, and these guys were very clever because they realized NHIF was unpopular because contributors were having procedures rejected. So they corrected that. How they corrected that? They approved each and everything. So as long as you are SHA registered, you walk into any hospital, you have a growth, you have a what, OTP on your phone very quickly, your procedures, they even send you the amount of money approved. So Kenyans flood hospitals. They say SHA is beautiful. They never rejected anything. And hospitals are trusting government because government said we will pay. Now, 11 months down the road, hospitals have sent to SHA claims worth 96 billion. Because, hey, Kenyans are going to hospital and SHA is rejecting nothing. 96 billion. And SHA has paid 53 billion. Now, if you do simple math, 96 minus 53 is 43 billion. Within 11 months, SHA is in debt to the tune of 43 billion Kenya shillings. It took NHIF 50 years to accumulate 33 billion. It's taken SHA 11 months to accumulate 43 billion. How much is SHA collecting per month? Maximum, they are collecting 6 billion. How much are we sending in claims by visiting hospitals? We are sending claims worth 9 billion every month.
So
every
we're sending
month.
3 billion shillings in excess of claims that have been received by SHA.
Deficit of 3 billion monthly.
Yeah.
So by the time 1 year ends, at the best, they are going to be at least 36 billion shillings in debt.
Okay, so
they're already 43 now. So we don't know how they are going to catch up. And we are now looking at the general public. Kenyans are not increasing contributions. Out of the 26 million Kenyans who have registered for SHA, and our politicians are very good at saying, register. They are not telling Kenyans, contribute. So Kenyans are registering. So out of the 26 million Kenyans, only 1 million self-employed Kenyans are contributing. 3.5 million salaried Kenyans are carrying 96% of the weight of SHA. So we have climbed up that tree of healthcare, and we are sounding an alarm. It is nothing to do with private hospitals want money, they are greedy. No. Sounding an alarm that if this situation is not sorted out, by the next 3 to 4 months, there will be no health system. All hospitals will go back to pure cash. Pure cash, because nurses have to be paid. You can't pay nurses with promises. How will they pay their landlords? How will they take their children to school? Suppliers have supplied drugs. Even KEMSA, which supplies government, is in big debt. We have a big issue, and we are urging the government to get away from the issue of when we ask for money, we are cartels. But when we were providing services, we were angels.
So we're going to go to hear what is actually happening on the ground. Well, of course, we're getting comments and we want to hear what some of those are. So do send us your comments. Our lines are open on our socials this morning on YouTube, X, and on Facebook. We want to hear experiences of folks going into the system and seeing exactly what that is all about. And so this is an all-inclusive conversation. Our Baraza panel is here as well to give some insights into this, because there is what it is on paper, Dr. Lishenga.
Yes.
There is what is in the law, and then there is what is on the ground in terms of what is actually happening. Exactly. So we want to go into some of that a little bit, and we'll start to then take some views from our Baraza this morning, and we'll just start with where the mic is right now. You'll just let us know your name and what it is that you do. And my first question is posed to you. We'll take the gentleman here in the middle. That tell us your name and what you do, and then give us the situation as per what you said, because we know that you are a community health promoter, and you'll tell us what area you are in and exactly what's happening with what you've heard and what you have seen.
Thank you.
Yes, go ahead.
My name is Samuel Mutua. I'm a CHP from Pajenga, Mukuru. the Ministry of Health.
Okay.
And county government. So
yes, Kiswahili ni sawa, ongea Kiswahili hakuna shida.
Sawa. So kwa pale kwa jenga sisi ni madaktari wa mtaani, na pale kwa jenga kuna kama vile mnajua ni kijiji, kuna challenges mingi katika kijiji sana sana tangu wakati hii mambo ya SHA ilipoanza. Tumekuwa na challenges nyingi kwa sababu kabla watu wana kijiji waelewe what is SHA na wakubali kuregister, ili take time kuwaelimisha, kwa sababu ni jambo tu likuja kwa ghafla. Watu kuelewa vile watu wanaweza kaelewa na mambo katika hizi kama huku tu kwa makazi haya mengine, sio vile watu wanaelewa na mambo pale kijijini. Sometimes you take wakati mrefu sana jambo likitangazwa na serikali haswa kuhusu afya, au watu wetu hao ambao tunaishi nao pale vijijini kuelewa ama kuruhusiwa kwa haraka. So SHA will take time. Unaona? Imebidi tukue tukuelimisha. Wengi wamelikubali na wakaanza kuregister mambo ya SHA. But bado kuna challenges kulingana vile ile SHA inafanya kazi. Sometimes kwa wengine inafanya, saa zingine inasumbua.
Ukisema inasumbua aje? Sasa
kusumbua ni wakati wa registration. You see? Unapata kuna mtu amechelewa kuelewa mambo ya SHA. Amekuja katika huduma hospitali, kutafuta huduma hospitalini. Ameambiwa lazima aregister. Ajiandikishe kwa ile SHA. Yule mtu unapata labda hakuwa tayari na hakuwa anaelewa lile jambo. Amelisikia wakati amefika wapi? Kwa hospitali. Na katika ile hospitali anaambiwa lazima akitaka kuhudumiwa lazima ajiandikishe katika SHA. You see? Na yule mtu labda ni mtu hana pesa. Unapata zile challenge zinaturudia sisi kama ma CHPs. Kwa sababu ule mtu umemwandikia, kuna kitu tunaitanga referrals. Amekuja kama kwa nyumba zako katika kazi ya CHPs kuna hizi units. Kwa kijiji chetu kama Jenga ward tuko na units karibu 7. Ni 7. Tuko na units 7 katika Jenga ward. Kila unit ina sehemu yake. Na unit moja inakuanga na CHPs 10. Wale CHPs 10 kila moja ako na nyumba 100. 100 households. Naona. Katika zile 100 households unapata ile nyumba ambayo iko na ile familia ambayo iko na watu wachache ni watu 4.
Okay.
You see?
So tuseme watu 40 already.
Sio 40. Ukihesabu nyumba 100. 100 households.
Okay, 100. Okay, time 400 people.
400 people.
Okay.
Ambao wanahudumiwa na mtu mmoja. Na miaka ni unaweza kupata mtoto ule first born ni 15 years. Na ule mdogo ako na 2 years ama 1 year. Na hao watu nafaa kuhudumia wote. You see? Unajua maisha pale kijijini kungangana. So, ikifika ni wakati wa huduma, lazima kuja kwako kama CHP, akuelezea, umwandike. Kama ukitembelea zile nyumba unapata kuna shida, umwandike ile referral mtume kwa hospitali. So hapo kwa hospitali ndio mambo yanaanzanga. Ule mtu maybe akuregister ile SHA. Na ni lazima hudumiwe, na ile shida ni urgent. Hasa shida za watoto. Unapata ule mtoto anahitaji ahudumiwe pale kwa pale. But because mzazi anaweza kuregister ile SHA, unapata ule mtoto itabidi atoke pale atafute private.
Kwa nini? Hiyo ndio swali nauliza. Kwa nini? Kwa hiyo hospitali hakuna nini? Hakuna madaktari ama kuna nini? Madaktari, hajalipa ama shida ni nini?
Shida ni ukiregister SHA.
Umeregister lakini haujalipa.
Okay. Na before uhudumiwe hospitali za serikali lazima upeane kitambulisho.
Okay.
Waangalie. Naona, wacheck kama you are registered na na umelipa.
Okay, so that's going to one of the problems that Dr. Lishenga is talking about here, where he says everybody's being told register, but people are not being told pay. Okay, let's hear from a number of other people. Can we? Let's hear from you, madam, in the back. Will you please tell us your name and what you do?
Good morning.
Good morning.
My name is Catherine Cheva. Nafanya kazi pale Maradaina.
Just speak up a little bit, ma'am, so we can hear you, Catherine.
Okay. Mimi majina yangu naitwa Catherine Cheva. Na mimi ni mhuduma wa afya. Community health promoter.
Yeah.
Nafanya na Jenga Hospital level 4. Na niko saidi Maradaina ward. So challenge ile tunapata pale unapata ni SHA. SHA unapata mtu ana register lakini ikifika wakati wa kulipa sometimes unaenda pale unapata unaambiwa ulipe 1 year. Kama unaenda una register kwa cyber. Vile nimeletewa na nitaletewa 850 mimi nilipe. Mwingine aletewa 650, mwingine aletewa 500. So unaona huwa ina differ. Na izaletewa hiyo 850 na niwe sina uwezo wa kupata hiyo 850. Niseme okay, sitalipa hiyo 850, after all nitakuwa naenda chemist. Ninunue dawa pale kama ni painkillers. Because ukienda kwa government hospital utaenda uambiwe ulipe SHA. Una hiyo pesa ya kulipa. Ama utalipa 1 year. Unaweza pata kuna wale beneficiaries nimebeba kwa familia yangu. Naweza kuwa niko na watoto na wana birth certificate. So wata benefit kutoka kwangu.
Okay. We're going to sort out a sound issue. Just kidogo, Catherine, tutarudi hivi alafu tutarudi kwako kuendelea na hiyo story kidogo as we try to sort that out. So, Doc, even as we are hearing already, before we get to more folks here, it just goes to what you're saying, that everybody can register. That is fantastic. But if you don't pay, then we will not be able to offer service. So then government is right. They've been saying for the longest time that SHA is working. As of Sunday, there were politicians who stood on dioceses across churches and said SHA is working. So from what I'm hearing so far, what we're hearing, they're right. SHA, if as it was originally designed, with all the moving parts in place, then SHA is working.
And
yes,
they actually are saying that when they go to hospitals, their experience is opposite, because at the point of access to service, there are 2 issues. One, during the registration, the premiums, and the lady is saying the premiums vary: 850, 500, 650, 1,000. Obviously, this is very unpopular. Because say you live in the same neighborhood, you have the same circumstances, your children go to the same place, your rent is about the same. People are wondering, and they talk to each other.
Yeah.
So why am I paying 850 and Dennis is paying 500 and we are just next door? We are both.
We're in the same.
Yeah, we are the same. So first of all, that's extremely unpopular. And we actually told the drafters of SHA that this method, which you are calling proxy means testing, where you ask somebody, do you have electricity, do you have water, is your house tiled, how many children are in school, how much is your rent, how much you spend on this method is going to be very, very unpopular, because after some time people will realize that the premium I get is dependent on the answers I give. Isn't it? And people will start gaming the system. Now, those who don't get this knowledge early will end up paying very high premiums, as they are saying, number one. 2, the requirement that you pay 1 year in advance for you to access care. That has also become very unpopular. And people are actually asking, we used to pay monthly under NHIF and we get care. Why is it that now under SHA we have to pay for a full year? 850, by the way, as Madam was saying, translates to 10,000 in 1 year. Really, how many Kenyans, if you just ambush them on the road with an illness tomorrow, tell them, give me 10,000.
10,000 up front.
It now becomes another burden to them. The other thing that they are bringing out very clearly is the issue of the care at the facilities. Is coming out as a point which we did not address. So the politicians are saying SHA is working. We are reversing the question and asking, for who? Is working for who? Maybe it's working for you, for your political sound bites, for you to be able to go on TV and say it's working, and to mobilize people to vote or something like that. But is it working for the people? And they are very clever about this. You know, in Kenya, over 1 year, only 20% of Kenyans will go to hospital. So these politicians with their sound bites are targeting the 80% who don't go to hospital and who therefore don't know the truth. So they are not giving the voice to the people who actually are accessing the service. And this is the problem. This is the real problem. So I'll go back and say this way, that for there are 3 people SHA has to work for. SHA has to work for three groups. SHA has to work for patients. And SHA will not work for patients when patients are being asked to pay 1 year in advance and their premiums are much higher. That's number 1. Number 2, SHA has to work for hospitals. If hospitals are not receiving timely payments, if you ask hospitals will say SHA is not working. The third people is SHA has to work for the payer. That is, it has to work for itself. Now, if you ask the SHA people, it depends on which day of the week you find them. If you find them on a good day, they say SHA is working, you see, patients are being treated. But that's dependent on hospitals. On a bad day, they say SHA is not working, you see, hospitals are stealing.
Stealing what?
SHA money, which is not there.
Oh my goodness. Well, I mean, we laugh because sometimes you are trying to diffuse the pressure in terms of, you know, what the situation on the ground is. And if you just look at a prescribed situation whereby you pay a certain amount of money, you expect that whatever the case, when you go to hospital, then you will be treated based on this model that we are essentially working under. That is what the case should be. So we're working with twin problems here.
No, let me shock you, Ndu. Like, we have a lot of CHPs here. And I have worked with CHPs in my home county, trying to do health promotion in the villages. And you know what CHPs shocked me? They told me that they are helping people register for SHA, but they themselves cannot register for SHA. And this is the irony, that community health promoters are out there in, going door to door in the community, register. And by the way, they also told me that people have become so clever these days. It is the CHPs themselves who are telling people how to answer the questions so that the premium goes down. And we told the government that, please, hii system ya kuuliza watu, asking people about their living standards, will never work. You would rather just have a flat rate that common mwananchi can manage. And the president, he came out. In fact, this is why people supported SHA initially, because he said, ule mtu wa chini, the person who is at the bottom, will not pay more than 300 shillings. And people felt like that was a lot of relief. But their lived experience is different. So CHPs are telling us that when they themselves took proxy means testing, the premium they were given, they could not afford. Because, the stipend that CHPs get isn't much. And so you're saying a CHP does a proxy means for themselves. It says your contribution is 1,500, 1,200, 1,000. It's expensive. It's unaffordable for them. But, the question then, because I started by saying that SHA is not raising enough money. I started by saying that compared to the number of people going to hospital, the claims we are generating, SHA is not raising sufficient money. The public are saying SHA premiums are too costly. Okay, so even as it is now, they are costly. The other reason why, and I know they will talk about is people used to go to certain hospitals, level 4 hospitals, level 5 hospitals, for their care. And now you are required to start at level 2, level 3. You start at a lower dispense. Even if you have a very serious problem, you have to start at the lowest facility for you to get a referral to go to the next. Sometimes you find that the hospital that is closest to you is that level 4 or that level 5. But now you are being forced to travel, you go and find a health center or a dispensary, and then you start again the process. These are all the accumulated problems that have made SHA very, very unpopular. We need to ask ourselves, why is it that when NHIF was at the last year of NHIF, we had 1.8 million Kenyans contributing. 1.8 million Kenyans contributing voluntary every month. Sometimes it would go to as high as 2 million Kenyans. Now, today under SHA, we have never gone beyond 1 million Kenyans contributing voluntary.
Why?
That is the question. We need to ask ourselves, why is it that half of the Kenyans who used to contribute voluntarily under NHIF have chosen to just stay out? They're just watching. And there are many reasons that are coming out here. One, the premiums. Okay, the premiums are problematic. The requirement that you pay annually. The hospitals that you used to go, now you can't use those hospitals. Now, there's also the political messaging that just register, you don't need to pay. Now, this political messaging is extremely dangerous because, as I said, we have 26 million Kenyans registered under SHA right now, more than we had under NHIF. Now, the vast majority of these guys have been told, wewe register wenda hospitali matibabu ni bure for outpatient. Now, when they go to outpatient, you know, some hospitals actually offer them free care once they confirm you have registered. Now, we have argued that 9 out of 10 reasons why people go to hospital are outpatient reasons. So 9 out of 10 times when people go to hospital, they don't need admission. 1 out of 10 times they may need an admission. Now, can you imagine if 9 out of 10 of the reasons why you go to a hospital is free? You know, you have been told usilipe. You only have one time when you need to have paid. Who is going to contribute?
And you know, it's interesting because I'm looking at, you know, Ruto's scorecard at, you know, 3 years. Amongst other things that he had promised, from agriculture to security to governance, devolution, healthcare was really, really key, and the promises that he made. And, you know, it's interesting, your last comments in terms of the political interpretation of this. Universal healthcare was a very, very big point, and the reason why people are really keen to understand, okay, so finally we're going to afford medical care when we go to hospitals. But I'm curious to know from our panel, how many of you, by a show of hands, you fully understand SHA from the point of registrations to understanding the premiums that need to be paid to who then qualifies to actually benefit from SHA, understanding inpatient and outpatient? How many here and fully understand SHA? See the shock. None of them fully is aware or understands then how SHA is essentially supposed to work. Then how do you communicate this messaging? Because the idea here is it's top down. So nobody has been, no stakeholder engagements, no training, no explanations, no talking to the people and explaining this is how this thing is going to work. And I will throw the question back to our panel, and we can hear more of the experiences, the questions that they hear from people, the engagements with the local people who are supposed to be then consumers of this. We'll go with the lady with the microphone.
Right.
Thank you. My name is Lena Mati. I'm a lawyer and also double as a public administration advocate. I want to start here being a public administration advocate. One of the problems that I feel we have as a country, right from the government to even us as a people, is the fact that critical decisions, critical debates like healthcare are not centered on what the experts are saying. They are centered on what the politicians are saying. Just want to echo what Dr. has said. Because you'll find that, and I appreciate for this conversation, you'll find that when you go to even the media, you know, our media is filled with politicians coming to talk about healthcare. But you look, a politician is in Camp A, let's say Camp A is government. So when a politician comes to a media space to talk about healthcare, of course they're going to favor SHA. Why? Because it's their work. I mean, it's your work as the government to support the government policies. You look at someone in Camp B, probably in opposition. Of course, because you're in opposition, it is your role to oppose the policies. So because of that, you cannot be able to look at things from a neutral point of view. And that's why I also thank that Dr. is here, because now we can be able to get an expert opinion. You know, you can be able to get a neutral point of view, someone that doesn't have any political affiliations. They can come and tell us that, you know, these are the things that are working, and this is not, and this is what is not working. Anyway, besides that, I'm looking at why is it that we went, why did the government come up with SHA? They felt like probably the NHIF that we had since around 1966 wasn't effective. It was outdated, it was inefficient, and there were also allegations of corruption. So when you ask me whether SHA is working, I find that to be a little bit more shallow. Yesterday, before I came for this interview yesterday, and actually even today in the morning, I managed to call up some friends of mine and ask them, have you used SHA before? Has it worked for you? Out of the 5 that I asked, 2 told me that it has worked for them or their family members. The 3 haven't registered. They don't even know how it operates.
Okay.
So now I'm asking myself, because one of the reasons why we came from NHIF was to increase coverage, make it efficient, deal with corruption and all those things. Has SHA managed to cure that? That should be the point of debate. When you talk about coverage, has it been able to cover a lot of people? Has it been able to cover the informal sector, the vulnerable, the poor? Can they be able to access health, in an affordable rate? Look at it in this way. Right now, we have the Primary Healthcare Fund. The Primary Healthcare Fund is funded by the government together with the Emergency Fund. And then the rest, the contributions, we contribute to the NHIF. So Primary Healthcare Fund, when you go to the hospital, I heard that, it's allocated 900 shillings per year. To be honest, 900 shillings is too small, to even cater for basic healthcare. 900 shillings divided by, let's say, probably get well like 3 times. That's almost like 300. And this is why Kenyans are coming up and saying, I'm going out to the hospitals to get outpatient services, basic healthcare services, but I'm not capable of getting them at that cost. So I have to dig deeper into the pocket and get more use more money to be able to afford these services. So is it really working? Secondly, look at it in terms of corruption. Has it been able to cure corruption? They always say that a good system, no matter how sophisticated it is, no matter how well-intentioned it is run by people, So if there is no goodwill from the people, in terms of personal interest to be able to deal with this system with the good, to be able to put effort in dealing with this system, then you're not going to have anything. It is still be vulnerable to corruption. And that's what I feel like SHA hasn't been able to achieve. On one side, I feel like, yes, there's something that it has done. But on the other side, I also feel like there's also something that you are missing out. Yeah.
Okay, well, let's hear from a number of others. We'll hear from you, ma'am. Just tell us your name and where you are operating as a CHP from. Let's use this other microphone, please. Well, actually, go ahead, Catherine. Catherine, you can switch back, it's fine.
I'm Catherine Nyongesa. Ninafanya na community health promoter Njenga Imaradaima ward. Attached to Njenga level 4 hospital.
Okay.
Sasa kulingana na vile tunaongea, mimi on my side naweza sema NHIF was a bit fair kulingana na hii SHA ya saizi. Juu SHA ya saizi actually ni shida. Hata mimi mwenyewe I'm a health promoter lakini si access. Aje tuliambiwa SHA inakuja kutuletea a bit fair kuliko NHIF. Aje kwa malipo. Tukaambiwa tutakuwa tunalipa ya chini less than not more than 300 shillings. But saa hizi ukienda ukiuliza hizo maswali utajibu ni yale maswali tu ya kawaida but tricky. Ukijibu inakuletea kitu kama 1000 plus. Unajiuliza sasa, I was paying 500 kwa NHIF and I was not able in other parts. Na sahi kama inakuja 1000, will I be able? Unaona unashindwa. Unaweza register ulipe, tulikuwa tunalipa hapo nyuma monthly.
Okay.
Una struggle, unalipa hiyo mwezi. Sasa ukienda pale, unaambiwa you must pay for a year. Sasa a year, if you are paying 1000 shillings, that is 12,000. Unasimama unasema, sasa mimi 12,000, if I am able to pay 1,000, how will I pay?
Kama una struggle.
Yes, 12,000 once.
Catherine, wacha nikuulize, watu wanalipa ndio wapate usaidizi kwa hospitali.
Yes.
Si ati unalipa ukingoja, unalipa wakati kuna shida.
Saa hii ukienda pale, for example huko umeregister, utaenda pale uambiwe first you register.
Okay.
So unajua when I register nitapata service. Unafika pale unaambiwa hautapata service without paying 1 year
in advance. Okay.
Unakuwa stranded, unarudi nyuma. Haya, nilikuwa nimeregister hapo nyuma, nimelipa. Nimelemewa. Unaambiwa kuna fine, sijui inapigwa ngapi. Kuna fine. Ulipe, alafu ulipe hiyo 1 year. Do get service. Sasa mimi najiuliza, kama tuliambiwa na government, yes, wanataka tuwe level moja. Mimi maoni yangu ingekuwa tungeambiwa tulipe kama niyo 3,300 sisi wote level mo au watu wa chini. which means hii SHA ni ya watu wengine wale wanajiweza zaidi kuliko watu wengi na ugonjwa naye haijui hiyo.
Yeah.
Sasa tunajiuliza kweli SHA itatusaidia ama tutafanya aje?
Okay. Tutarudi. Let's go to you, ma'am. You ni sawa.
Okay. My name is Edith Wangari. I work for an advocacy group that works at grassroots level. And on this topic of SHA, whether is it working or is not working, the other week we were in Merti, in the interior-most part of Isiolo, and we had an accountability forum whereby we called the community itself, we called the healthcare workers, so that we can have a very conclusive conversation. Where is the problem? And part of the problem was the lack of information, whereby women and the community are saying we are not publicly engaged in these things that deals with health. We are just when the laws are there, we're just being told do this and to do this. So there's no public participation in any way whatsoever. So we can't really accept that we're supposed to pay this money because we really do not understand where is it going to. So there is that lack of public participation, lack of information at community level that's leading to even all this confusion around SHA, whether should I pay or not, because you haven't seen it working, and now you're being told you have to pay so that you see it working. But if you go to the health facility and your friend has told you, I went there, I'm registered and it's not working, then even you'll just step back and say, I'm also not registering and I'm not paying for this SHA.
And we're looking at issues around what then health actually does look like. We're going to hear from a number of you, two gentlemen to my right here, and we'll just hear from you, your names and what you do, and let us know what the situation is on the ground. And it was interesting, that question that you asked Okari earlier, that we don't even understand how the thing is supposed to work in the first place.
You're supposed to then educate the public or explain the process to the people coming to you, and you yourself are not even aware how this thing goes. Then there's a very, very big problem. But there's another conversation that the problem we're also having is that people are going to register and pay premiums at the point when they are sick. So ukifika pale hospitali ndio sasa unataka matibabu, then unajikuta ujaregister, hapo ndio unataka kwanza kuregister na uanze kulipa, unlike how it was working with the NHIF. I don't know whether that is also another issue that now is on a problem that is now coming from this other end. And the gentleman with the microphone at the back, you can stand and then say your name, what you do, and your comments.
My name's Joseph Macharia, community member and youth leader at Kariobangi North, and I'm also a member of Kariobangi Social Justice Center and Mama Zetu CBO, and also a CHP community health promoter. So I would like to state part of the Constitution, Article 43, Part 1 of the Constitution states that every person has the right to the highest attainable standard of health, which includes the right to healthcare services and reproductive health. But from my angle of understanding and view of SHA, it was a good project and idea. I think it was borrowed from the western side of the world. But it has faced a lot of glitches and hitches here and there because we didn't build the right infrastructure at the inception stage. So that's why we are seeing issues of like currently we are still facing issues of inadequate medical supplies at the healthcare facilities. We still don't have we are still having inadequate number of medical personnel at the health facilities. And that's why we are also having issues of interns striking, the nuns on the strike, because SHA is not yet self-sustaining. So as much as it is being inasifiwa sana na wanasiasa, bado iko na changamoto sana mingi hapa kwa ground. Na ndiyo maana there is a lot of mistrust about SHA because there was no enough public awareness and understanding about SHA. So I think we still have a long way to go. And well, just like Daktari has said, if SHA doesn't maybe clear the debts that are being owed to the other the public and private facilities, in the next maybe few months we'll be having a crisis. And it's a high time that the government takes charge of the situation, and so that tuweze kufanya kazi safi kwa wananchi pale kwa ground like CHPs, sababu tukienda pale kwa households, people still think that SHA is like NHIF, ile ambayo ulikuwa tunachukua NHIF unaregister kama ni bibi ama mzee, pale ndani yake tunaweka bibi na watoto wanakava wote hivyo. Lakini sasa SHA ni different, sababu as long as you are 18 years old, you are an individual on your own na unafaa kuwa covered on your own self. So tunapata inakuwa na hizo changamoto, sababu ndio umeregister, but if kama wewe ni CHP na ujui kujaza zile premium test questions, utajipata kwa shida, sababu utajazia client and then pale premiums zikikuja pale chini, the monthly premiums, unapata the amount is too high. Like mimi nilijijazia yangu and monthly yangu ikakuja ikaingia 1200. So if you multiply 1200 times 12 months, that is 14,400. And if you look at my incomes and revenues, they don't even total to that in like in a month.
Collectively.
Yeah, collectively. So unapata mimi kulipa ile 1200 for in a month, naona kidogo ni challenge, because kwa akili yangu mimi nilikuwa najua pengine ni ile ya 300 ingekuja kidogo haingeniumiza. So naona kuna changamoto mingi na we still have a long way to go.
A long way to go.
Thank you.
And what about you, sir?
Hello, my name is Steven Odongo. I work at the grassroots level of Kariobangi North with the young mothers, matters maternal and newborn health. And the experiences of SHA out there are different. Many people are still stuck in between the old NHIF and the SHA. And they are wondering what next. We are told to register, but there is no clear explanation of what happened to our contributions on NHIF. And now the problem is there is no clear information. The politicians are just politicizing the matter. And currently, I'm working, for example, with a cancer patient who is required to pay an upfront of up to 1 year in premiums to SHA before she starts the chemo processes.
Okay.
And now she has to stay at home to raise that money. A person who cannot even afford that common bread. So the cancer is eating into the body because it's waiting to pay for 1 year treatment. So it's a challenge.
So I'm sorry, Odongo, 1 year treatment or 1 year of premiums?
1 year of premiums.
Okay.
Yes. And for that is difficult for people without income. Recently, doctors have been on strike, and many people ran to private hospitals to get assistance for those who are delivering. They go there and they are told that, if you are going to deliver through a CS, without SHA, you will pay up to 60,000 cash. And with SHA, you will pay a little bit lower. So they are like, I cannot even raise that a 1-year payment. Where am I going to get 60,000 cash? So it is a problem that is facing the people at the grassroots level.
Let's stay there a little bit more, Dongo. Can we kidogo too? So this is a woman who is not going to get pregnant. Si ati anafikiria atapata mimba mbeleni. Saa hii akona mimba. Right?
Yeah.
Anafaa kuenda kujifungua. Sindio?
Yeah.
And she's told ukileta cash ni 60,000.
60,000.
Na ulikuwa umeshasema kupata chakula on a daily basis is already an issue.
It's an issue.
Right?
Yes.
And we are now saying kujifungua utalipa 60,000 kama unaleta cash.
Yes.
It's a little bit less with SHA. But SHA haujalipa hiyo 12,000
Yes.
for the year.
Yes.
So the question is, wamama wanaenda kujifungua wapi?
Now that is where the problem is. Yeah. Because that already adds to the existing problems for most health centers down there, where even when you have paid that premium, the beds are not enough. Some health facilities do not even have medicine. They have to write for you to get it out there. Yeah. So it is a problem, and I think we need to have a serious conversation about the whole SHA stuff, and that the politicians, the leaders need to come out and to start telling people the truth that we need to build trust with SHA, because this is public money. If they messed up the old NHIF, then this new model, it's a good idea, but can we have a clear conversation with everybody so that they can understand what they are dealing with and they can benefit? Because few people maybe they are benefiting from it, but many are still questioning what is it. Yeah.
Maybe we can hear from this gentleman who hasn't spoken, and then we can go to Daktari.
Good morning.
Good morning.
My name is Simon. I'm a community gatekeeper at Mukuru. And also I'm the chairman of Embaka South Community Health Promoters Association. That's Association of CHPs. And also working as a coordinator in the climate works in Mukuru Kwanjenga. So for now, on the issues of SHA, that is working, not working, to me is like you are not seeing trees and the forest at the same time. Because current people are jobless, some are so vulnerable, such that to afford medical services through SHA, they can't. And one of the president was saying that the vulnerables would be allowed to be treated free. Yet, there's no criteria, there's no mechanism put in place to identify the beneficiaries. So, that meaning all clients who are sick at the households, they are yet to get to hospital because they can't afford. Simply because when you get into any hospital, you ask a public hospital, you ask for SHA. That's the first time. And if you are not registered, then duly you are to get registered, and you have to pay for the treatment. So you just get away. They are getting to the chemist around.
What? Okay. Sorry. People are coming to hospital with issues, with
Yes.
medical problems.
The vulnerables.
Tell me some of the issues. Ugonjwa gani wanakujanga hospital nayo?
So kuna watu wanapitia magonjwa kama NCDs.
Kama nini?
Kuna
high blood pressure,
wenye wa blood pressure, diabetes. That's also cancer.
Cancer.
Tuweke zote hapa.
Sasa ukikuja ukienda hospitali na wanakuambia uwezi pata usaidizi juu haujalipa
SHA,
unaenda kwa chemist,
you just unaishia tu kutoka tu kurudi kwa nyumba.
Kufanya nini?
Na hauna njia utatibiwa. Hauna njia. Unless you get a cash, unaenda public hospital or private hospitals. you
So,
get a cash.
Unasema watu wanarudi nyumbani juu hawajapata usaidizi, wanarudi na ugonjwa, wanarudi kwa nyumba.
Yes.
I want to talk to Catherine just a little bit. You had tried to talk to us before we had a bit of a sound issue. Ndio shida pia wewe unaona, ulisema unafanya kazi huko Mkuru?
Yes.
Okay, tell us please.
Mimi chenye naona pale unaenda unaregister. Watu wengi wameregister. Yes. Lakini kulipa wanjalipa. Kuregister si ni free. Mtu anaenda register. Akimaliza kuregister anakaa tu. Siku ya kwenda hospitali ndio anaenda anaambiwa pale mpaka ulipe 1 year. Ndio access services. As for me, nilikuwa na client nikalipa 1 year 6,000, alikuwa amelipishwa 500, nikalipa 6,000, alikuwa anaenda delivery. After 3 days kama amejifungua mtoto akawa discharge, then akawa mgonjwa, ikawa niende higher hospital. Vile nilienda ilibidi sasa for the first time nimelipa SHA 6,000. Sasa ni kwa outpatient, nitoe pesa kwa mfuko. Nikienda pande hii unalipa, ukienda pande hii 3,000, ukienda pande hii 2,200, 300. At the end of the day akawa admitted. Though alikuja kutolewa yes na SHA, lakini umelipa SHA ikusaidie, na tena unaingia kwa mfuko unatoa cash. So hiyo kitu ikawa imenichanganya sana.
Kuna kitu umesema, kuna that example ya mtu ameregister lakini watu hawalipi. So watu wana register juu ni bure, hawalipi juu hawajui wanafaa kulipa, ama ni ile unajua unafaa kulipa lakini kwa sababu uko mgonjwa hakuna haja ya kulipa, lakini wacha ni register. Lakini ile siku uko mgonjwa ndio sana kimbia hospitali, then unaambiwa kwa system records zinaonyesha umeregister lakini hujalipa, sasa lipa
premium. Unapata nimeambiwa pale nilipe 8, kama mimi nimeambiwa nipe 650, sina hiyo 650. So wakati mwingine unaona ni challenge kulipa. Sasa wanakosa kulipa kwa sababu ya pesa. Hawana hiyo pesa. Mtu amepewa pesa yenye hawezi lipa, hawezi pata. So anaona kuliko niendelee na kungangana na hii pesa, na mimi maybe ni naumwa na kichwa. Naona niende pale chemist ninunue Panadol. Though sijapimwa lakini ninunue Panadol. Nimeze. Na utakaa tu mpaka sasa sini hapo sasa. Hiyo ndio shida tuko nayo.
You know, it's interesting. I went to a chemist. I've just remembered this. I mean, this flu cold that is doing rounds.
Yeah.
So I went to this chemist and there was a queue. And I stood there waiting. I knew what I wanted to buy, but there was a queue. And what I observed is people are now resorting to use the people behind the counter to consult.
Yeah.
So you're going and explaining, because the assumption is this person who's giving you the medicine ni daktari. So namwambia nasikia naumwa na kichwa, kifua unasikia, nasikia, na hii nasikia, because you're not paying for that, it's free. Then they would recommend medicine. The challenge now with that is it's so easy to take medicine from somebody who's not really qualified to diagnose because there's no testing at that chemist. And my question to daktari, listening to this conversation, it almost, because I'm hearing two things. I'm hearing, one, there is the issue of, looking at the general conversation, SHA and access. There's inadequate medical personnel. Somebody raised it, that you go to a hospital, the doctors are not enough. Then there's the issue of lack of medicine. Even if you access, still not enough. So which brings me to the beds are not enough, which now brings us to this question. Giving universal health care and access, was SHA then fixing an access problem but not care? Because it almost seems like, fine, if you've paid the premiums and then you can access, there is another challenge. Either there are not enough doctors and nurses, there's not enough medication, or there's no equipment, you want to go for dialysis, there is nothing you can do, but you still have access. Is SHA fixing an access problem only?
So, first of all, the last 20 minutes, I have just been listening to the panel, and we have a very good panel. This is very intense, even for me to hear, despite being on the provider side. The experiences of Kenyans, vile mmesema kwa ground, and before I even, okay, let me just answer your question straight. So, SHA was not fixing an access problem. If you look at, SHA was fixing a funding problem. So the drafters of SHA, the idea they had in mind is that we need a lot more money to cover many more Kenyans. That NHIF wasn't covering enough Kenyans, because the total number of at peak, if you contributors plus dependents under NHIF was 15 million. 15 million, that's the best we did. We have a country which is 55 million going 60. So their argument was, you are only covering a quarter of the population. That is too few people. And therefore, a lot of people are incurring, the sound bites. Harambes will be over, all those things. So the first problem they tried to fix was a healthcare financing funding problem. And to that extent, they had some good ideas. Let me give you what the good ideas. Primary healthcare fund, independent, funded by Parliament. Fantastic idea. Emergency chronic and critical illness fund, which was to align our financing with the constitution, that no Kenyan will be denied healthcare because of an emergency. So they set up the Emergency Chronic and Critical Illness Fund, again funded by Parliament. And then we have the elephant in the room called the SHIF Fund, which is what we are all discussing, the contribution. Now, if you realize, during the first budget, the financing to primary healthcare and emergency was very low. And people made a lot of noise about that financing. In this current budget, they increased it to 13 billion for primary healthcare and 10 billion for emergency chronic and critical illness fund. The 13 billion for primary healthcare is being dispersed. Some counties are getting, some counties have problems. About, some 8 or 10 counties have problems. Other counties are getting. The emergency chronic and critical illness fund, unfortunately, has not been activated. Even if you look at the data of claims coming in for ECCIF, it's for the 10 billion, the last one, a few months, they have only generated claims worth about 500 million, very little, very small amount of claims. So that fund is not active. And if you ask them today whether they know, if I am in an emergency, I can go to Aga Khan, most people don't know. People know that they can go to Nairobi Hospital.
You go in an
go
emergency?
To Mata. According to the law, if today you have, you get run by, hit by a motorbike in Parklands, if you are Ruko Parklands, you are walking and you are hit by a boda accidentally. The law says you can be rushed to the nearest hospital, which will be Aga Khan Hospital or whichever.
And they must treat you.
And if you are SHA registered, even if the bill within the first 24 hours is 500,000, SHA should pay. But
how many people know this?
How many people know this? People don't know this. They don't know. If you have an accident somewhere on Agwings Kodek, and the nearest hospital is Nairobi Hospital, the law says for the first 24 hours, whatever bill they incur, even if it's 1 million, SHA will pay.
Will pay.
Now, how many Kenyans know that?
Nobody knows
I am sure, even in the communities where you are, you see accidents every day, mtu amegongwa, and when they are taken to the hospital, they ask for money up front. But the thing is, the Emergency Chronic and Critical Illness Fund is funded, but it's not activated for two reasons. I don't know why they are not educating people about this, to tell them this benefit is there. And number two, for us as providers within our SHA portal, we need to have activation of the module, so that when a patient comes in as an emergency, I know, okay, Erastus is here, he's been run by a vehicle, I will click here, I will submit a claim. That is not there. So the healthcare financing was the main issue. But I will say this: where is the rain beating us on the public side?
Yes.
Education, obviously, you can hear people don't know. And by the way, this government has been taken to court numerous times because of the issue of public participation. Numerous times. In fact, these SHA laws almost fell because of lack of public participation. They have not done effective public participation. The public participation they have been doing is for checking a box. They just want to show watu walikutana mahali, wakaongea, waka-tick box. But they have not really invested in telling the Kenyan people because, and I think largely is because of politics. Because if you know, when you take this thing to the ground and you tell people the reality that your premiums will go up, the politicians are afraid that it will make them unpopular. So they gloss over it. The other thing is, let me just, on that healthcare financing issue, somebody mentioned it here. If you are over 18, you are now a household. Isn't it? If you are over 18, you are considered a household unless you show that you are in school or something. But generally, you are a household. So I want you to imagine families where you have mzee and mama and 3 children who are all over 18, because we have employment crisis in this country. A lot of kids are staying home well past 18 into 20s, even 30s now, because there's no work out here for them to go do, so they stay in the same house. Now that house with 4 people, everybody there is an adult, has an ID. Do you know everybody there is a contributor in that same house? And yet maybe the person who has income in that house is one person. Only one person. Now, these are the problems, this is a major problem. We proposed to them. We proposed to them that instead of having everybody in the house being a contributor, because they will not, that burden is impossible. Okay? Why don't you have like a family package? You say, this house, nyumba iko na watu 4, let us give them a flat rate. Wakilipa hiyo, the whole house is covered. These are basic things that they haven't done. The other basic thing is like with the lipa sha pole pole. Let lipa sha pole pole actually be lipa sha pole pole. It cannot, it should be micro premiums. Allow people to pay daily, weekly, monthly, kulingana na uwezo ya mtu.
That's an interesting, Dr. Lishenga. So I just want to hear, would it make sense, for example, Saeed, because we have people, and this is the scary thing for me, because when we look at other matters of health, I'm trying to imagine, if we just look at maternal care, there's Odongo works with maternal care, for example. A woman is pregnant to give birth. And she can't do that if she's not paid, obviously. And she doesn't have the cash, even if it was 20,000 shillings, which is a third of what it would cost at the hospital. Even if it was 20,000 bob, she doesn't have that money to pay. We already know, for example, that with maternal death, that postpartum hemorrhage is one of the highest causes of maternal death. We know cervical cancer is the number 2 killer for cancers in Kenya. The number 1 is breast cancer. These are non-communicable diseases that people cannot go and get treatment for in hospital. We can't even do prevention, which according to the Ministry of Health, we are going from curative to preventative care. Scanning cannot happen. So many things cannot happen at the same time. But a mother who is about to give birth, just as an example, and doesn't have the care, I'm still asking the question, where does she go? What does she do? Do we have more women giving birth at home? Do we have more women giving birth where she is and there's somebody who's going to rally around to help her? Because what are we talking about here? And that last question that you asked, do people, even if you were to pay a little, what would make sense? Because these are the issues.
Maybe I can take the question of what would make sense. And we have proposed this. In this country right now, we think that a fair premium on average should be somewhere between 600 and 900 and no more. Should not go there. So that would be like the most effective premium. But we need to break it down to something like 20 bob a day, 150 a week, 300 a month, or whatever. We need to break it down to manageable levels so that wananchi can actually afford it. There are so many good ideas. For instance, why haven't we used chamas as aggregators for helping the community to pay? And chamas can do this very well. We have a lot of chamas out here. If you go to any particular ward, I don't know how many chamas you can find. You can find hundreds of chamas. But we can incentivize chamas to be collectors for us and give them a small token, 0.1, 0.5%. If your households are contributing under the chama, we give them some check, a bonus over the. Do you know what we are doing with these empowerment rallies that politicians are doing? You gather women groups and you give them, and people end up with 64 bobs, 100 bob. What if we converted those empowerments into SHA drives, so that, for instance, if a chama is very effective in getting people to contribute this small amount of money, they get their 50K check. Okay. Why not?
Does it make sense? I mean, it's the lady in the purple. Sorry, just remind me your name, because you talked about working in the grassroots. We know these chamas. We know women. Catherine, both Catherines can tell us. And also we know that it happens, for example, that you are in a chama whereby you're putting 50 bob on every Tuesday, you're putting 50 on Friday, you're putting 20 on Tuesday. So maybe in a week here, ukisema, you can get 300 bob in the different chamas, and then on what day you collect. It happens, doesn't it? So would it make sense if for even this SHA, because it's a problem, people are sick, right? Would it make sense if they say, put a little bit of money, if 20 bob a day, because you can gather it, 20 bob a day, let it go towards SHA. If that came up, would it make sense?
I absolutely agree. It will make sense in that perspective. But there's a survey that we conducted where we asked women, what do they want for their health? And surprisingly, one of the key things that they say they want is money. So it comes down to money. But where do we get this money? This woman can't afford the 6,000 per year that she's been requested for. But with the 10 shillings, 20 shillings each day, she's able to contribute that money towards the M-Pesa. If you can have the M-Pesa, what the doctor was saying, let's have the Lipa Pole Pole for the SHA. So we... And the question around even maternal health, because we also work within maternal health, where right now we are seeing a rise in women now giving birth through the traditional birth attendants. At least during the Linda Mama, those cases were coming down. But right now we are seeing a rise, and also we are seeing also a rise in maternal health, in newborn health. And today, even the WHO is now... The key things that they are focusing on is bringing down the maternal deaths and neonatal deaths. But if we cannot fix the financing issue, then I don't see ourselves fixing the maternal health crisis that is happening, fixing the neonatal deaths crisis that's happening at the community levels. And we have CHPs here, and they will tell you, right now women are afraid to go to the hospital to seek the skilled birth attendants because they know they'll get charged. Within Linda Mama, you'll go in and come out and your services are free. But right now you have to consider now, I have to have cotton wool. For example, we provided even some cotton wool to within the communities because you're asked, you cannot go to this hospital without cotton wool, and cotton wool is one of the essentials that you need when giving birth. So if this woman does not have that cotton wool, what will she do?
Wait, just hang on there. This is very heavy. And sorry, I mean, it's your reality on the ground. On this other side, these are horrendous stories we're hearing. So you're saying this mother has to look for cotton wool. Is this communication from hospital that, look, ukikuja kuja kama umejipanga, or how is it happening?
It's communication from the hospital. You come with the maternity pads or the cotton wool that you need. So even when we're doing activations around, or we are teaching mothers about maybe how to take care of their pregnancy at community level and giving them basic information, they tell us now, you have given us the information, but when I go to the hospital to give birth, I need that cotton wool. I need that to provide that cotton wool. I need that maternity pad, and I don't have the money for it. So they're asking us if you can provide for us so that when the time comes for me to give birth, I'll go with these things. And maybe the CHPs can confirm this because we have them here. And we have done this in the community, Kariobangi community. Also, we did it like 2 weeks ago where we provided women with cotton wool and maternity pads. This is the reality on the ground, and maybe they can confirm this for us so that we...
Well, I mean, Odongo is sitting next to you. He works with Maternal, and also Catherine is there as well. So maybe we can hear from both of you as well.
Yes, that is very true. When it comes to expectant women, they need these essentials to use during delivery. Now, apart from the contribution they need to pay in the hospital, they need to have these things with them. And that is also trickles down to the the finances they need to have with them. So about the chamas, it's a perfect, brilliant idea, but it may not always be the case, because most people live from hand to mouth. Even the little they get to feed the family, they need to maybe spare and keep for this. Okay, pregnancy is about 9 months. Sometimes you live with a person who is not well off. They don't have income, and therefore you are basically yourself. So you need to have these things ready by the time you are delivering. So it is difficult. And basically I've heard also recently that many children have been detained in hospitals because of the huge bills. So if the delivery comes, you have to go and deliver whether you don't have any money with you or not. So once you have delivered, you see, they will keep you there until somebody comes along and maybe settles your bill. So it is still a problem for many women.
Yes, ma'am.
Asante. Kuhusu, nitaongea juu ya vile daktari amesema vyama. Hakika hata tukifanya vyama ni vizuri, but we shall not cover the whole community. Juu kuna wale watu wa chini kabisa. Kama sisi community health promoters, tuna end up by, wewe unakula kwako, maybe umestruggle, umepata yako, umekula. And your household neighbor to you, akona watoto, na hata hawezi raise 20 bob.
20 shillings?
Yes. Kuna watu vulnerable, totally vulnerable. Mtu kama huyo tiari atabaki nje, hataweza hiyo chama. Wale tu tutaweza ile chama, huenda ni wale watu wako well off kidogo, wale ambao tunaona hata 6,000 per year, it's a lot. Sasa hiyo hatuta cover the whole community. Juu kuna watu wale hawana kabisa. Kabisa ukiona, unaona hana. Mpaka anaenda kutafuta huko chakula yenye imetupwa huko anakula. Mtu kama huyo hata 20 bob hawezi.
Na watoto?
Pia analeta tu hiyo, kama amepata. Kama ametoka, watoto pia wametoka, wameenda. Unaona sasa situation kama hiyo ni ngumu. Nikikuja kwa mama wajawazito, ni ukweli. Hakuna hizo pads, hakuna hizo cotton wool. Wewe CHP mwenye uko na household yako, unapeleka mama pale. Hapo nyuma vile kumekuanga hata na hiyo linda mama, utagaramia. Utajua vile huyo mama atatoka kwa nyumba, hata kama ni saa ngapi, kwanza security wise. Umpeleke hospitali, ujue vile atajifungua, hautamuacha huko na mdambu. Mpaka ujue vile atatoka arudi kwa nyumba, hata kama akona watu wake utasaidia. Sasa ikifika hapo kwa cotton wool na nini, kama hana, you will provide kama health promoter.
You will provide from where?
Wewe sasa utajua juu hii ni kazi yako. Tumekubali. Tumekubali kufanya kazi ya community. Kitambo tulikuwa tunaitwa volunteers. But sasa ndio community health promoter juu ya stipend kado. Hiyo 3500. 3500 hata mimi mwenyewe siwezi jilipia hiyo SHA. Nifanye yale yanatakikana, na ni obvious 100 households 3/4 maybe hawajiwezi vile tu mtu anaweza kujisustain. Alafu kitu kingine, daktari
unapatiwa 3500 per month.
Yes, stipend.
Ndio stipend mnapatiwa.
Yes.
And you're working every day.
4 hours.
Mtu akikuita saa 8
utaamka. Yes. Utaamka.
So kwa hiyo yote hiyo fare itakuwa ni yako.
Wewe ndio utajua vile huyu household wako atafika hospitali, na uwezi waacha, uwezi lala.
Na akihitaji hiyo pamba na hiyo pads
utapeana saa hiyo juu wakati hiyo maybe ni hiyo household yenye iko vulnerable kabisa. Hakuna hata mtu wake utaenda kusema leta. Utabeba hiyo mzigo. Alafu kitu kingine ni challenge haswa mimi nimepitia. Tuko na watu kutoka nchi za nje kama Uganda, Tanzania. Mtu amekuja Kenya, ni household yako, hana ID, hana chochote, maybe ako na mimba. Ni challenge pia. Ukienda pale hawezi register SHA, hawezi fanya nini, ako tu hapo na anataka usaidizi kutoka kwa CHP.
Can I just
Please, because clearly,
You see,
okay, yes, please, sir.
Unaona hii kazi ya CHP ni kazi ngumu sana. Kile wenzangu wamesema hapa ni kweli, tunapitia hali ngumu because unapata uko na hizo households pale, services kwa zile public hospital zile ambao tumekuwa attached kama CHBs, unapata vitu zingine hakuna. Ukipata kama huyo mama ambaye ni mjamzito anaenda kujifungua, amefika pale ajifungua, yes maybe akona uwezo wa kulipia hiyo SHA, atalipia, but at the end of the day pia kuna pesa atalipa. Unapata SHA inalipa nusu kama amelazwa, na yeye kuna ile pesa analipa, SHA ilipi yote. You see? Na kwa sababu ya those challenges, alafu pia zile services kwa zile hospitali, zile facilities ziko low. Kuna vitu hakuna kama hizo umesikia hawa. Kuna mmoja nilipeleka nikashangaa, na ni usiku saa 9 usiku, nimepeleka mama kajifungue. It's serious. Naambiwa ni kwanza nitafute gloves za daktari.
Ngoja. Unaenda hospitali?
Napeleka
ama kuna mahali ingine?
Hospitali. Napeleka mama kajifungue. Unaona? Na amebakisha tu masaa. Nimeitwa saa 9 ya usiku. Nimetafuta gari, nimeomba jirani gari akanisaidia tukapeleka. You see? Kufika pale hospitali, kitu ya kwanza daktari anakuambia hana gloves. Just gloves.
Ni saa ngapi?
Saa 9 ya usiku.
So ukatafute gloves saa 9.
Sasa nitafute gloves. Kwa bahati nzuri kuna wakati tulikuwa tumepatiwa gloves kwa nini zetu, ikabidi nirudi kwa nyumba nikalete zangu.
Huyo mama sasa yako wapi? Amewachwa hapo.
Sasa ako pale, daktari anagoja nimletee gloves ndio aanze kazi. You see? So tunapitia mambo mingi na tunapata kwa saa hii namba ya wale watu wanatibiwa kwa hospitali za serikali imerudi chini. Wengi wamepotelea kwa my chemistries because pale watu sana kwa hizi vijiji zetu unapata yule mtu ambaye anategemewa pale maybe ni mama mzee ana kazi, na yule mama kazi yake ni kufua, anafanya kazi ya kutafuta kufulia watu. Hata ipata kila siku. Ile familia iko na watoto 3 wote wako shule. You see? So ukitokezea shida ya afya, hiyo shida inarudi kwa CHP, yule mwenye ile household. Na before ukienda pale kwa ile household umeitwa, before waanze kuongea jambo lingine, labda ni mtoto mgonjwa, unapata maybe yule mtoto ile shida ako nayo ni kukosa kula vizuri, amekosa chakula, maybe ni mtoto wa under 2 years, amekosa ile chakula bora. So magonjwa, shida ni kukosa kula. Sasa utaanza pale kwa chakula. Huyu naona na ile stipend ni 3500.
So
you see, so hii mambo ya SHA at least Linda Mama ilikuwa inatuokolea. At least Linda Mama ilikuwa inatuokolea sana sisi ma CHP. Because ilikuwa inaturahisisha kazi. Hata kama utasaidia au utasaidia kama sahi. Sasa unaitwa mahali unaanza kwa kununua unga kabla mfike hospitali. Unaanza kwanza kununua unga, unapata hata hiyo nyumba maji ya mtungi 5 shillings hawana.
Oh, come on.
You see? So imekuwa kazi ngumu sana sisi kwetu. Unaanza pale kwa nyumba, ndio chukua hatua sasa ndio utabeba mama upeleke hospitali. Hao watoto watakula nini? Ukifika hospitali kuna challenges. Unaweza kaenda pale ule mama atibiwe ama ule mtoto atibiwe, atoke at the end of the day. Akitoka kuna dawa hakuna huko. Ameandikiwa.
Kuna dawa hakuna wapi?
Hospitali hakuna dawa.
Please, daktari, I'm sorry.
Unaona? Ukitoka pale na hiyo dawa, wewe ndio unapatiwa kadi. Huyu mtu uliacho umenunua maji na umenunua unga moja na sukuma 2 kwake, ndio umekuja hospitali. Tena pale kuna
uliwacha chakula kwa nyumba ndio watoto wakule, ndio mama apelekwe hospitali, na akifika kwa hospitali unaambia uende ulete gloves number 1, hakuna dawa.
Unaona? So unajiangalia, unaona sasa hata kumpeleka hospitali kazi ya bure kama hawezi kupata dawa. Unabidi wewe tena uhangaike ununue. Uanunulie hizi dawa. You see? Yani
maybe so what I can say as you can see and the numbers they are giving are true. From the data we have SHA data. This is our own data at level 2 and level 3. Private hospitals and mission hospitals are accounting for 79% of all visits. So it means that Kenyans who are going to public hospitals are only about 20-21%. The data at SHA actually shows this. And what this says is that at the lower level, at level 2 and level 3, where most of our CHPs are attached, that the county governments have literally shut down. They have let us completely down. And it goes against the rhetoric that we hear from the politicians who are saying that public hospitals, the amount of money they have received under SHA, they have never seen since independence. Now, when you go to actual public hospitals, you don't see the money. And we are wondering, we passed one of the laws, the Facility Improvement Fund Act, which was supposed to make sure that even your level 2, even your level 3 can open a bank account, and when they see patients under SHA, that money is supposed to come back to that facility. But what we have seen in many counties, that the level 2 facilities and the level 3 facilities do not have critical supplies, which means they are not receiving the money that was promised under the law. And I know what has happened. A lot of these counties, they see patients at level 2 and level 3, but the account number that they have given to SHA belongs to the Department of Health. So all the money, that's supposed to be coming directly to the level 2 or level 3 bank account never gets there. So this is
that's why you will go there and they will tell you to bring gloves.
There will be nothing. Let me give you another shocking statistics. Out of the money that SHA has paid out, 40% of the money of SHA has paid out has gone to specialized services. You know, and this specialized, I'm talking about orthopedic surgery, general surgery, neurosurgery, urology surgeries. Now, how many hospitals are seeing those specialized services? Only 28% of claims are
specialized care,
specialized services. So 28% of claims are eating 40% of the money. Yet our level 2 and level 3 hospitals don't have resources.
And the level 2 and level 3 are actually taking up the bulk percentage of ailments that people are presenting to hospital with.
Bulk of patients.
And the money's not going
every time we see our politicians visit hospitals, you never see a picture of them at a health center. You never see a picture of them at a dispensary. You will always see a picture at the referral hospital,
and the few people
at the big private hospital with very nice cameras and nice things. But they never go down there where the services are actually being accessed. The other thing I would mention, do you know SHA right now has a funding deficit, as I said, of about 3 billion shillings a month. If we just reduce the contribution to 300 bob per person and we got 10 million Kenyans to pay, we have no gap. So why are we insisting that the contribution has to be something unaffordable? We can put it down, make it affordable, more Kenyans will be able to pay, and we will be able to meet the funding deficit. I also want to put this challenge to especially the county governments. Under the NHIF, and I really hate it that politicians have been spending the last few months just telling us how NHIF was bad. And yet most people know it had challenges, but there were some things it was doing well. For example, Linda Mama was great. Okay, for example, Edu Afia for children who go to school was fantastic. We had the orphans and vulnerable and elderly people package, indigents, wale wazee ambao walikuwa wanalipiwa. That was fantastic. Yeah, even what's the even the UHC was perfect. So there were a lot of good things, and we told them keep these things.
I just want some clarification just from some of you here. Under Linda Mama, wamama walikuwa wanaingia hospitali kujifungua bila malipo.
Sasa wakati wa Linda Mama kulingana na sisi ile vile kwa ground kuiko. Wakati wa Linda Mama every month maybe kwa wa unit, hata ripoti ya hospitali mali huwa tuna report mama walikuwa anajifungua, but now unapata ni hili mama akajifungulia private. Unapata mama uko naye kwa household ako na mimba, lakini wakati wa kujifungua ukifika hata utajua, maybe aende nyumbani akajifungulia nyumbani kienyeji ama apelekwa private, kwa sababu ya zile challenges ziko wapi kwa zile hospitali za serikali.
Okay,
let's hear from Wakili here.
Yeah.
Thank you. I'm not really a medical practitioner, but from what I'm getting from our panel here together with our daktari, I'm just wondering, was this system worth that we're told that was worth 100 billion plus? Was it worth it at such a time? Because probably could have improved our maternal health care. We could have improved the welfare of our community providers. We could have done something with equipping the hospitals. And come to think about it, this was rather a very rushed system. You know, it's whereby something is thrown to your face, so you're still trying to figure out, ini kiti hospitali, you know, what is it, what does it do, and all that. There was very minimal consultation. Just from basing my arguments on what he has said, there was very minimal consultation that were done, because I believe that some of the things that we are saying, even the gap that you need to pay 1 year before, we could have at least have had a chance to sit down with medical practitioners and experts and ask them, how can we be able to cross over from NHIF to SHA, and also like be able to cater for these kind of gaps, so that we don't have people coming out and saying, if you cannot be able to pay for 1 year, you cannot be able to access medical services. You could also feel that some of the things also that we are SHA is going through, there are things that can be dealt with if at least the Ministry of Education, Ministry of Health sits down with the real people on the ground and gets to understand, rather than just politicking.
Okay.
But anyway, they told us that they passed it for the president. So I mean, we're not surprised.
We're not surprised.
We understand.
Doctor, because I mean our time is running out and there's still so much to talk about. But I often have to ask the question that the vanguards of these policies, the vanguards of these processes, these stories that we're hearing today, are they aware that there's no medicine? If you go, they're telling you must go buy your medicine somewhere else, that you must go find gloves at 3 a.m., that a mother cannot get into the halls of a hospital to deliver because she's not paid. Do they know that this is the real situation for 79% of hospital visits? 79% of hospital visits are in this cadre of level 1 and 2. Number 2, I don't know what the other statistics are in terms of exact numbers, but a majority of people who are going then are also not able to afford, because medicine is not available. You're told to go somewhere else, and because you've not paid, you then will not get the attention that you need. Do they know?
They know. In fact, some of them are even texting me here saying, you have said this. They're even listening to the show. So they know. They know that, for example, level 2 and level 3 hospitals are not getting sufficient funding. They know. They know, for example, that they have been paying ghost hospitals. They know. This is a reality. If you look at the payment, and we've pointed it out to them, that, by the way, this hospital you are paying here doesn't exist, this one doesn't exist, this one doesn't exist, this one doesn't have, and the good hospitals that are actually existing are not getting money. This is what I would say and do, that the government needs to do very basic things. If Kenyans go to hospitals and they find hospitals have drugs, they have equipment, and they have motivated staff, Kenyans will contribute.
Yep.
This is the point. They need to understand that the only party in this system that is holding SHA together is the healthcare workers, from the CHPs to the nurses, to the doctors, to the health centers. If that group stops supporting the system will collapse. So the reason why the system is working is because of sacrifices by CHPs, sacrifices by nurses, sacrifices by hospitals that continue to treat people despite receiving no payment and having no... The day those people say enough is enough, the whole thing, the emperor will be naked. And this is why when we come out and say, you need to make sure that our hospitals have resources, it is for the sake of the Kenyan patient, because we can see what Kenyan patients are experiencing. It is not fair for Kenyan patients to go to hospitals and have to carry cotton Okay, and when we say, why is the hospital not having cotton? Cotton costs money. Why is it that the money is not being released by our county governments, our national governments, to make sure that our hospitals have funds? It's because of politicization. So, I mean, if you ask, why would we spend 104 billion on a digital system that still pays fake claims? Does that make any sense? Why would we be saying we are spending 200 billion on equipping the biggest hospitals which already have everything, and yet our health centers and level 2s don't have basic commodities? It's because we are used in this country to making decisions based on which vendor is going to get paid.
And unfortunately, we cannot allow lives to continue to hang in the balance. We hate to end this show like this, whereby we're sending folks back into an existence that is so difficult. But it was necessary for us to talk like this. It's necessary for us to air these things and give the real situation on the ground. Thank you, each and every one of you, for making it Spice Baraza this morning. Thank you for sharing and being honest and open. It is our hope that things get better, but we have to bring them out in the open. Thank you for talking with us this morning, each and every member of the panel. Dr. Brian Lishenga, thank you also for being here.
Thank you.
And for never flailing in the position.
Thank you.
Thank you, all of you, for keeping it the Situation Room this morning and for keeping the conversations open. Righteous continues.
This is the Situation Room, the only way to start your day.